Hello, everyone, and welcome to a new session with Rights and Responsibilities Awareness Initiative. Today, this is our fourth session with Ernest Johansson, and today is a very, very important session, addiction prevention. So thank you so much, Ernest, for being here with us today.
Thank you. I'm very glad to be here, and I'm very passionate about addiction in particular. And it's helpful when people understand it, and it also gives people hope for treatment. And people do get better. Like that's one of the underlying messages is, every addict has the potentiality to get better, and that tends to be lost on people sometimes, and people get kind of there is a lot of misunderstanding about addiction, which is very counterproductive, and it kind of moralizes the addiction itself. And that is contrary to what you have to do to give an addict treatment. And also, addicts, they don't recover until they want to recover. And that's another portion of it. But I'm very passionate about these issues, and I'm glad to be here.
Likewise, sir. So the floor.
Awesome. Well, addiction. I'm oftentimes people kind of struggle to know what addiction is. And I think the best working definition of addiction is a relationship with any mind altering substance or behavior that the individual does not have control of. In other words, virtually all over the world, there are mind altering substances kind of culturally around. Certainly alcohol in North America and Europe, cat in places in Eastern Africa, stimulants in Northern South America, what have you, absinthe in Europe, what have you. There are all these mind-altering substances that are relatively just spread throughout cultures in the world. And not everyone who uses a substance is necessarily an addict, and not everyone who doesn't use a substance doesn't have the potentiality to be an addict. And then there are behavioral addictions as well, which can be shopping, there's sexual addictions, there's gambling. There are elements of some eating disorders that can be addictions, although that's kind of a different category in general. Shoplifting can be an addiction. There's a wide variety of addictions, and essentially you can be addicted to anything that spikes dopamine levels. So the most accurate working definition of addiction, I think, for our purposes, would be a relationship with a mind-altering substance or behavior that an individual does not have control over. They have to use or engage in this behavior to maintain homeostasis. Now, that might sound kind of broad, but I hope to explain it a little bit more in order to kind of clarify. There are three elements of addiction. There's behavioral or psychosocial. There's psychological, which is actually in the chemistry of one's brain. And there is there's psychological, there's social, and there's physiological. And so the physiological is essentially the substance that needs to be in your body for you to have homeostasis. Your body gets used to a substance. And the most simple kind of description of this that you can have would be caffeine. People will have a cup of coffee to wake up in the morning, and then if they habitually are dependent on the coffee, they might have two, and they might have three, because it has diminishing effect. And that's a sign of a physiological need for homeostasis, and you still want that kind of bump of the coffee. Now, it's relatively benign. A potentially lethal dose of caffeine is incredibly high, far more than one could reasonably achieve drinking even energy drinks. But nonetheless, it is an example of a physiologically dependent relationship. Behavioral addiction, or behavioral component of addiction, rather, is the pattern of behavior associated with the use of a substance or the behavior. So for someone who's an alcoholic, for instance, they might have certain places where they constantly drink, watching sports on TV, going out with their friends, or it could be even alone. or what have you. But it's the behavioral pattern that they have related to the substance. It can be mowing your lawn. You always have a beer in your hand, for instance. And then the psychological, and this is perhaps most important because it's ultimately rooted in this, is what is it doing for your brain? What is it doing for your emotional state? And this is something that has been talked about a lot. And I think it really illustrates going away from the moralistic kind of judgmental treatment that sometimes is associated with treating addicts. And that is at a baseline, the vast majority of addicts, what they're doing is it's a pattern of behavior to assuage deeply rooted trauma. In other words, a significant amount of addicts, and the numbers are well over 98%, have early life trauma, if not abuse. And the degree of trauma can vary. Trauma is relative. Um, but the point is, addictive patterns grow out of your brain not having better tools to manage trauma and not having a safer capacity to manage trauma. Gabor Mate is a New York-based writer who has written a great deal about this, and he's spoken many, many times throughout Canada, the US, and the world, and I highly recommend his works around addiction. He's kind of industry standard. So with that definition in place, in order to treat addiction, this is a simplification, mind you. There's certain sociologies related to substances that complicate things. But in order to treat addiction, one has to allow the addict to have the tools to live day to day without the substance or behavior. And then on a deeper level, have tools to manage that underlying issue that was being managed through addictive patterns. And sometimes you have to redo their entire social network. And there are various ways you can do this. But ultimately, without addressing all three components of addiction, the physiological, the psychological, and the social, without addressing those three elements, it's going to be relatively incomplete treatment. And so there are various methods to do this. There's psychotherapy-based methods, and there's 12-step methods. People talk a lot about residential treatment, and outside of addictions in the legal system or in popular culture, residential treatment or rehab is kind of bandied about as that's what you do with addiction. And so a couple things about that. Residential treatment actually has a very low success rate, and there are sociological factors around that. I want to be clear, it does work for some people. However, insurance companies, court systems, if someone, has a drunk driving conviction, oftentimes they'll be ordered into treatment or rehab. And one of the problems with that is rehab only has like a 12% success rate. And then sometimes when someone is ordered there, and it's commonly done, their odds of their success is very, very low. So principle number one is an addict has to want to get better and be committed to getting better before it's going to work. And sometimes when people are forced into treatment, they might learn a little bit, but they're not going to necessarily maintain long-term sobriety. Now, it typically takes longer-term addicts about 12 to 13 tries in order to maintain long-term sobriety. And so there's different phases of recovery. There's pre-contemplative, where basically the addict is very much tied to their pattern of addiction. And in that addiction, they'll do whatever they have to do to justify their behavior. Most commonly in family systems, they'll externalize responsibility. I wouldn't have to drink if you didn't talk to me this way. They will minimize the impact of their behavior. It isn't a big deal. I only had 3 beers at dinner or whatever it is. They will lie about it. I wasn't drinking. That was water. Meanwhile, it was vodka. And they'll simply hide it, drink in a closet, hide alcohol in the trunk of their car that no one else drives, or what have you. And that's typified in pre-contemplative addicts, essentially. Then there's contemplative, where they're considering there could be another way to live and starting to question some of their behavior. And a lot of addicts get there at some point and then bounce back to pre-contemplative. Sometimes there's a lot of shame associated with their pattern of behavior associated with addiction. Sometimes there's a lot of consequences they would have to face. And, what do they do when they can't face something? Well, they engage in this addictive pattern. Therefore, they don't have to face it. So they'll go to contemplative, maybe I should change this, and then have a pun not necessarily intended, a sober thought about, well, if I'm really problem drinking, then I've been lying to my family this whole time. And then they retreat back to drinking. And then from pre-contemplative, there's the early action phase. And this is where people come into mental health crisis centers. This is where people start calling services and start exploring what to do. And a lot of times people don't know what to do. And that is when they might still engage in the addictive substance or behavior, but they're starting to make inroads in terms of speaking with professionals or joining 12-step groups or what have you. It can be a religious group, can be a 12-step group, it can be whatever it needs to be. And they start making some changes. And then there is prolonged sobriety, which is basically they start living their day-to-day life without the substance or behavior and start working on other therapies or treatment modalities or anything that helps around the deeper underlying issues. Now, I talked a little bit about rehab. Most rehabs are governed under or operate based on what's called the Minnesota model of addictions treatment. And the Minnesota model basically surmises accurately that an addict's life is chaos, which it often is. And if they provide a very planned out, structured pattern of life for some period of time, and residential treatments are anywhere from 12 days to 90 days or even 6 months, depending, that all the addict has to do at that point, once the structure is provided for them. So essentially you get up at 7 a.m., breakfast is at 8 a.m., chores are afterwards, your first meeting of the day is at 8:45 through until 10 p.m. every day. That all they will be able to do in the context of that structure is work on their issues. Now, like I said, rehab has a relatively low success rate for a couple of reasons. One of the most vulnerable places is that the patient's lives don't go away once they get out of rehab. And what are they going back to? What support systems do they have? What skills do they have in a less structured environment? And another is, as I mentioned before, there's a lot of people that get pushed to rehab and don't necessarily want to be there. Now, that's not to say rehab doesn't work for people, but I think rehab works better when it's combined with a kind of a therapeutic-based model. However, nonetheless, rehabs do exist. There are many in Ontario. Most of them have at least 50% OHIP beds, although the OHIP-funded beds generally have a longer wait. There's also private funding, either through insurers or through out-of-pocket. There's private funded beds, and those are a much shorter wait, but it's the same treatment program either way. Then there's 12-step or peer support groups. 12 steps are based on Alcoholics Anonymous, and they have 12 steps. They tend to be religiously based, although not necessarily entirely. And you will see a lot of 12-step based programs that are successful for the participants. And one of the pros about 12-step is that they have a built-in support network. There'll be a group of people who are committed to sobriety who know each other. The fundamentals are you engage in these 12 steps, the first of which is admitting they're powerless over a substance, and there's 12 step for behavioral addiction as well. And the 12th step is making amends. So with that in mind, the pros of the 12 step is the immediate peer support. I would argue the cons, and now keep in mind, people get sober with 12 step, and my attitude towards anyone getting sober is do what works for you. So I'm not to say it doesn't work for people. I just don't think it's the most efficient method. One of the cons is the way they treat relapse. They treat it as day zero. In other words, someone is no longer sober if they relapse. The reality is, as I stated earlier, most people trying to get sober make about 12 to 13 attempts before it sticks. And if someone has, let's say, 8 months or 9 months sobriety, and then they relapse, treating that as day zero, while it does kind of maintain the integrity of the program, it can also push people away, because that notion of I screwed up and I have to start over from scratch is very overwhelming for people. And the reality is relapse happens, and there's a lot of reasons why relapse happens. And However, that doesn't mean the person is starting over from zero. An individual could relapse and then be immediately back committed to sobriety and um, have some of the tools that they've learned and some of the skills that they've learned throughout the period that they were sober. So I think that that kind of all or nothing attitude towards sobriety is sometimes detrimental. And also there's a certain sociology related to the 12-step groups. They really, for instance, if it's a community that has a particular religious bent, for instance, there is a lot of, I was working in an area where there are a lot of Lutheran churches at one point, and the 12-step programs tend to be dominated by Lutherans. And if someone else was Catholic or Muslim or Jewish or what have you, that would have been a barrier to participate in that particular 12-step group potentially, because kind of in that particular area, there's kind of a cultural hegemony, so to speak. And then there's therapeutic models, and basically therapeutic models use various combinations of behavioral therapy, CBT, DBT, MI, what have you, and combine that with likely talk therapy and coaching on sobriety and psychoeducation on sobriety. In my opinion, these modalities work the best, and also you can combine modalities. Lots of people do 12-step and therapeutic modalities. And it's kind of designed for the individual's needs. In other words, if someone has a shopping addiction, you don't have to worry about the physiological impacts because it's not physiologically manifested. And it's more just behavioral therapy, changing one's relationship with shopping and giving them control over that relationship. But for instance, I need to talk about withdrawal, and I will in a second. But if someone's has a different type of addiction, like it's methamphetamines, you might engage in what's called harm reduction, which is basically the addictive behavior continues, but you make it less dangerous. And the sociology around methamphetamines is very, shall I say, rough. You're dealing a lot with homelessness, a lot of lack of basic needs. And harm reduction, basically, you can't really treat the addiction where the person is suffering like that and that marginalized. So what you have to do is help them acquire food, clothing, and shelter. And then maybe you can coach them to use a substance that is less harmful, like switching from methamphetamines to cannabis, for instance. And then at that point, you can begin working on sobriety if that's what the client wants. Otherwise, you've kind of reduced the harm of their addictive behavior, which also has value. 12-step programs and rehabs don't really do harm reduction, and it's a little bit of a controversial topic. But one thing I like to say to people is that in doing harm reduction, you're giving someone ultimately, even though you might be allowing them to continue the addictive behavior or substance use, dead people don't get sober. And in doing harm reduction, you're giving that person a chance to get sober. And that's sometimes seen as controversial, but the reality is you can't treat people who are dead. And I'd much rather have a live addict than a dead addict, because the live addict can get sober. Now, withdrawal. Withdrawal is related to physical addictions, and any substance that's physically addictive has withdrawal symptoms. Some of them are relatively benign. I mentioned caffeine earlier. Caffeine is physically addictive, and most adults who work full-time I don't want to put a percentage on it, a significant number have physical addictions to caffeine. What does that mean? The withdrawal symptoms: headache, irritability. That's manageable. But that is a withdrawal symptom. Now, some withdrawals are incredibly painful. Opioid withdrawals are very, very painful, and they basically feel like the worst flu you can imagine times 10 for a long period of time. And there's withdrawal management treatments in which people are giving a low non-narcotic, like medicinal dose of Suboxone or methadone, which the substances can take away the capacity for one to get high on the substance, but at the same time, they don't go into the withdrawal symptoms. And then slowly they're tapered off, or they just stay on the withdrawal management medication, and that's okay too, because they're not, they're not spending money they don't have on it. They're not stealing to procure the substance. They're not engaged in injecting in things like that. So it's very measured and controlled. It's a form of harm reduction, and it can be used to wean someone from the substance. And actually, the most physically dangerous withdrawal is alcohol. A lot of people don't know that, for a couple of reasons. I think there's a lot of stigma associated with narcotics, but alcohol withdrawal can actually kill you. And long story short, not every alcoholic is physically addicted to alcohol. It takes 10, it depends on the individual, anywhere from 10 to 12 standard drinks a day, all the way up to 20 standard drinks a day or beyond, even, for someone to become physically dependent. And when they become physically dependent, the symptoms of not having alcohol in their system are quite severe. Sweats, insomnia, shakes, they get the DTs, and there's a very significant tremor. And then they have alcohol and they don't have the tremor. And long story short, their liver can shut down if they don't have alcohol. And people in alcohol withdrawal need medical treatment. Usually they're prescribed medication. They need to seek medical help. And they generally will go to what's called a detox center, or withdrawal management center. And at those centers, the individuals are medically monitored. There'll be counselors and generally nurses on site who take care of their well-being, whether not using the substance. Now, keeping in mind that is a very significant amount of alcohol. That doesn't mean that someone who doesn't have physical dependency on alcohol isn't an alcoholic. It's about your relationship with the substance. Are you in control? And are you drinking, in this case, drinking, to manage feelings, or are you drinking because you like to drink? And I cite alcohol because it's generally the most common damaging addiction. Men are more likely to drink alcoholically than women, for reasons I spoke about before. And when one works in the addictions field, especially in therapeutic models, this is for sociological reasons. A disproportionate number of your clients tend to be middle-aged males trying to avoid drinking alcohol, because lifestyles associated with narcotics tend to cause people not to be able to make it to treatment. And it's a little bit harder to get treatment. That's not to say that they don't need treatment, but alcoholics, in particular middle-aged male alcoholics, tend to be overrepresented in professional circles because that's who can access services. One thing that I meant to mention earlier is that when someone has an addictive behavior or addictive substance use, it becomes something that is deeply recessed in their brain. They tend to, it goes into, as I mentioned before, there's the lizard brain, and that is fight, flight, freeze. It's very reactive. And it's something where, since I'm kind of in the woods right now, I use this analogy all the time, but it's very apt right now. If a bear charged at me, I would go into fight, fight, freeze mode. I wouldn't, think about the type of soil it stepped on. I wouldn't think about the type, beyond a rudimentary look. I wouldn't really think about the type of bear too much. I think of, how do I keep myself safe? And it's a very reactive, immediate thought. Now, for an addict, it becomes fight, flight, freeze, use. So if there's any sign of distress, it's a very almost subconscious, it's very ingrained deep in your brain, urge to use. It's like distress, I need a drink. Distress, I need to use whatever substance. And part of treatment, as I said before, is changing a relationship, taking it out of that reactive core of your brain into something where you have control. And it's a long, drawn-out process. It can be done in various modalities. CBD, DBT, MI, I think work very, very well. But that's fundamentally it, is you're changing the individual's relationship with the substance in which they don't have control of it. Addiction is a lack of control. It's a lack of connection, even to your own brain. There's other facets too. A lot of times people who engage in addictive behavior will have people in their family that are very tied to it. Codependency to addicts is a very significant problem. Also, children of addicts have very particular mental health features into adulthood, often related to anxiety, often related to the need to people please. And sometimes a significant number of adult children of addicts will themselves be addicts. And actually, there's kind of a very binary distribution. A very high percentage of adult children of addicts will engage in addictive patterns themselves, or a very high percentage will live totally sober. When I was a kid, they called it straight edge, where basically no substances, no alcohol, no cigarettes, no drugs at all, just no substances ever. And I mean, one doesn't have to live that way, but certainly if one wants to, by all means, I think that's a good way to live too. So yeah, there was one other point I wanted to make, and that is naloxone. Naloxone is important to have because it can literally save someone's life. It is very specific. It is for opioid withdrawal, or it's for opioid overdose, sorry. When someone has too many opioids in the system, they will fall asleep and they'll have very shallow, slow breathing, tend to make very guttural noises, and their body will be very limp. It's more a loss of consciousness than going to sleep. And basically what happens is their central nervous system shuts down and they stop to breathe and they suffocate. What naloxone is, it's very easy. You can get it for free at any pharmacy. I know we have a supply at our crisis center. And basically they are little like nasal sprays. The container is probably that tall. And all one simply does is nasal spray up the nostril, wait a couple minutes. Usually people will take 2 doses and then administer to the other nostril, put the person in recovery position, and having already called 911, wait for medical professionals. What naloxone simply does, you can't hurt anyone with it. It's harmless. All it does is it blocks the opioid receptors in your brain, and the person immediately comes out of their high, and their central nervous system perks up. People who are in this position will sometimes wake up very angry because opioids kill pain, and they'll wake up feeling all this pain that they've been numbing, physical pain. And it tends to be very chaotic. A lot of times individuals won't want to stick around for the medical professionals for various reasons, well, sociological. But it's very important that people are aware. However, naloxone is only for opioids. If someone, passes out drunk, naloxone doesn't help. I think I can give an overview a little bit about what various substances do. There are 3 basic types of substances. There's uppers, stimulants, depressants or downers, and then there's hallucinogenics. Hallucinogenics, the most common one is marijuana, and THC has a hallucinogenic property and CBD has a depressant property. So hallucinogenics, what they do is they warp the messages your central nervous system is seeing. So basically you might perceive any stimulus differently, touch, sound, sight, what have you. The individual will perceive it differently. There's extreme examples in pop culture. Alice in Wonderland is essentially supposedly a stimulated trip on a hallucinogenic. But basically what happens with hallucinogenics is the messages to your central nervous system get warped, and you're not necessarily hearing or seeing or feeling what you would normally feel, hear or see. And then depressants are just what they sound like. They slow your central nervous system down. The most common depressants are probably alcohol, and then opioids, and then CBD from marijuana. And essentially what they do is they slow down your response time, they slow down your perception, they slow down your heart rate, they slow down your breathing, they slow down a lot of your regulatory systems. And so everything slows down. Common problem with depressants is that it can just shut down your central nervous system. And also with any substance, there are certain pressures on your kidneys and your heart and lungs and your liver that they might get overworked if there's a significant amount of them in your system. And then stimulants, and the most common ones, well, I did mention caffeine, but caffeine is relatively benign, although it is a diuretic. So people who drink way too much caffeine and not enough water will get leg cramps and such. And it's not really good on a hot day because you need to drink more water. And so, I mean, if that is the only issue with one's caffeine consumption, drinking 2 parts water to 1 part caffeinated beverage is a really good thing to do. But caffeine's relatively benign, but it is physically addicting. So, I mean, keep that in mind. Then, of course, there's nicotine is a very common stimulant. Again, speeds up the central nervous system. A lot of times people will feel um, withdrawal from nicotine is very, very bad. Lots of irritability and drowsiness. So it becomes, it's very, very chemically addictive, and the behavioral addictions associated are strong. And then after that, um, methamphetamines and cocaine. And one of the problems with methamphetamines and cocaine both is that they spike your dopamine levels incredibly high. And what happens is one is not able to feel a lot of things that normally would make people happy because your endocrine system gets worn out, and you just can't produce enough dopamine through normal human activities. So when people are addicted to those substances, when they first become sober, it's a very, very depressive state because their brain doesn't have the capacity at that moment to produce feel good chemicals. Um, and honestly, that would be a good state for residential treatment for a couple of reasons, but neither here nor there. And there's other stimulants. I mentioned cats before. There's stimulants from all over the world. Um, and I mean, I could go on about the origin of many, many substances. It kind of, the sociology of substances also fascinates me. But I think I should probably stop there to allow for questions because I've talked for half an hour straight. But I'd be happy to answer any and all questions about addiction right now. I'm sorry, I can't hear.
Thank you so much, Ernest. That was super informative as usual, as always. And I need to reconsider my morning coffee after hearing what you've just said. Well, actually, I have two questions.
Yes.
For the nicotine,
Yes.
smoking, uh, usually in some cultures, my culture is one of them, we don't take it as serious as other
Right.
addicted stuff. Still, it's proven, it's written on the tobacco bags that it's dangerous, it could cause a lot of stuff, but sometimes you can't just stop.
Yes.
Which will lead me to the next question. Why we can't just say no?
Um, as a treatment modality, just saying no doesn't work because um, it doesn't address the underlying issues related to why people do it. In other words, if you were offering just say no with, let's do therapies on this underlying trauma that's driving you to do it, or let's do therapy, or let's, engage in procuring a livable wage and housing such that you're not on the streets and having an abundance of substances on the streets and um, having the trauma of being on the streets, uh, just say no doesn't come with that. Um, and I think in particular, this might be a controversial thing to say. I think of Nancy Reagan and the Reagan presidency in the US. And just say no was part of a wider pattern of reaction towards addictions and substances. And without going too deep into it, because I think we could spend hours talking about that, um, one of the things associated with that was a vast expanse of the criminal justice system in the US. And in that, there are people associated with substance use that have long-term prison terms when really the most appropriate thing would have been treatment. And the US has abysmal stats on addiction and recovery, but has the highest prison population in the world. And a significant number of them, something like 60%, are related to substances. And simply put, just saying no and moralizing it does not work. The countries that have the highest rate of addictions recovery are actually Norway, Sweden, and Portugal. And those countries, if someone is caught with a small amount of a narcotic substance, cocaine, for instance, they are not charged. They are assigned a social worker and mandated treatment. And sometimes it'll take a long time for that to take. And that's okay. As I said before, addicts take 12 to 13 times to usually have it take. But they have a much better recovery rate. And frankly, if one wants to just break it down to economics, a social worker in treatment is cheaper than long-term incarceration. And I hate it when human life is broken down to economics, but that's the reality of it. It is cheaper to treat people humanely and get them treatment as opposed to incarcerating them. And I see incarceration for addicts as
Mhm.
an intention of just say no. It doesn't work.
Mhm. So, do you personally support the theory of course, there's different theories, different points of views. Do you support the theory of having punishment as a prevention policy
Abs-
through addiction?
Absolutely not. It doesn't work. Um, I mean, keep in mind the sociology of substances. Like clearly, there's things that unfortunately, need to be punished. You know, an addict will steal stuff and barter it and what have you. But simply put, for someone to uh, be punished for using a substance, it doesn't treat the addiction. It just creates more prisoners. It drives people further into kind of subcultures that are related to substance use where there's less of a way out. And again, the US has a huge prison population, highest in terms of percentage of population in the world, and a very poor recovery rate. The places that have high recovery rates do not endorse substances as or don't endorse incarceration as
Mhm.
something to be as a
Punished
treatment.
with.
Yeah. Um, so simply put, it doesn't work. There's a huge amount of moralization, which is counterproductive. And as you said before, related to nicotine and cigarettes or cigars, some places view it as very culturally normal. I remember talking to my mom, who's from South America, and she told me when she was a kid, it was just the adult thing to do. You smoked. Adults smoked. It's just what, you're not a grown up, you don't smoke. Um, and so there is a huge cultural element too. And I'll use the example of cocaine. Cocaine is derived from cocoa leaves. And basically, in parts of Bolivia and Colombia, and other places in Latin America, they grow naturally, and indigenous peoples would chew them as a stimulant for centuries. Um, Now, it's illegal to cultivate cocoa leaves in a lot of places in the world, but that's a sociological relativity. The process of making coca leaves into cocaine concentrates it by a power of like 10,000 fold. So it is a megadose of cocoa leaves. But the physiological stimulation one gets from chewing 3 cocoa leaves is like having a cup of coffee. So there's a sociological element where like we're going to say this substance is bad, but we're okay with this substance, and it's really it's the behavioral pattern associated with the substance and the um does someone have control over the relationship with the substance or not? And it's actually not necessarily the substance; it's the relationship with the substance.
Mhm. So I would like to invite our followers, our audience on the social media platforms. If you have any question, please use the comments to ask your question and they will be asked accordingly. And meanwhile, I would like to ask you, Ernest, what about the medical drugs?
Like opioids?
You know, stuff they give you to reduce pain,
Yes.
and then you find yourself addicted.
So this could be another topic in and of itself, but long story short, um, opioids are very addictive and they have been used to manage pain for a long time in medical fields. What happened, particularly beginning in the 80s onto relatively recently, is they were overprescribed, especially in the US, but certainly in Canada too. And what happened is that people would have an injury or a surgery, and in the process of using these prescribed medications, they would develop a dependency on them or a full blown addiction. And then it became very problematic. People were dying, they were overdosing. And then, in addition to that, if their prescription ended and they didn't get another prescription, because a lot of times doctors wouldn't necessarily taper people, they would just end the prescription. They would then turn to illegal substances. The quality and quantity of the psychoactive substance in whatever people are buying from street drugs very significantly, which increases the risk for overdose. In other words, one can purchase fentanyl or carfentanil on the streets, but you don't know how many times the street slang would be stepped on, i.e. meaning cut. You don't know how many times it's been cut, and you don't know the quality of the substance itself, because carfentanil and fentanyl vary significantly depending on the source in terms of the potency. And these would be people who are engaged in street drug culture who came from after a medical procedure. And that is very, very common. So, yes, the medical community has often not been cautious about the prescription of opioids for a multitude of reasons. And that has ended up with people engaged in addictive patterns in a way that is they didn't necessarily want. And it's very unfortunate. Now it's much harder to get an opioid prescription. And additionally, it's much more controlled. Doctors are more cognizant about tapering and what have you. So on a lot of levels, that's been mitigated. And then also people with such prescriptions can seek withdrawal management treatment, as I mentioned before, taking Suboxone or methadone through a clinic prescribed by a doctor, and then taper that way. It's a controlled taper, which doesn't have negative side effects, or it has side effects, but it very minimal side effects relative to using street drugs. So
yeah, it's a long story. So
it
I
is.
think that might be an excellent topic for maybe
I would be
another
glad to
session
do
in
that.
our. Thank you, sir. So at the end of this session, I would like to express my heartfelt thanks to you, Ernest, especially that you are streaming with us today while you are in your vacation. You
Yes,
took this time from your vacation time to, just do this noble action to support this cause, hoping that we could save one individual, which would be great. So thank you, thank you, thank you
you're very
from
welcome.
the bottom of my heart.
Thank you. I am very glad to talk on these issues. I'm very passionate about mental health and addictions and just helping people be well. So I am very glad to do this. And yeah, I don't have big trees like this, like outside of my bedroom window or anything. So
So thank you so much, Ernest. And for everyone, thank you for joining us today. And we are looking forward to see you at another session with rights and responsibilities. Stay well and stay safe. Bye-bye.